Everyone to joint grand rounds for this year. This is actually very interesting. Not only is it a joint grand rounds with our surgery colleagues and perhaps our anesthesia colleagues, but also it's a day where we see a lot of orthopedic surgeons wearing suits, which means it's Wiley Visiting Professor Day. We have a very exciting presentation for this morning. So I'm going to do our introductions here, and then I'll hand it over to Dr. Jarvis to introduce the Wiley Visiting Professorship. And then I believe Dr. Seth will be introducing our visiting speaker for this morning. So I'd like to begin by reminding us all that Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. With that, I'm going to hand it over to Dr. Jarvis, who is live. We are doing a hybrid, first time ever hybrid grand rounds. Hand it over to Jay Jarvis, who is in the room, and you can take it over from there.
Okay, well, thank you, Mona, and welcome everybody. Welcome to the 27th annual Pediatric Orthopedic Wiley Visiting Professor Day, named after, let's see, how do you advance these? Okay. Named after, of course, Dr. James Wiley. Now, some of you may remember Dr. Wiley. I suspect many of you do not remember him or have ever known him. So I'm just going to take a minute to say a few words about Jim. Jim was a graduate of the University of Ottawa, Faculty of Medicine, 1955. He practiced initially at the Ottawa General Hospital, and then in 1974, when CHEO opened, he came over here with Bill McIntyre, and those two were probably the first pure pediatric orthopedists, certainly in this part of the country, and there were very few in Canada at that time. Jim was very active in clinical research and medical education. He was eventually promoted to professor of surgery. He was active both locally and nationally and internationally. He was a coordinator for his Faculty of Medicine year, but he's also assistant dean of postgraduate medical education. He held many offices within orthopedics and was notably the president of the Canadian Orthopedic Association. Jim had many talents. He loved to teach, he loved to write, he was a really good carver, and he was also a really great raconteur. He loved telling stories. And he used to tell them to us as we were doing rounds. He used to do rounds walking around the ward at that time, and he would tell his anecdotes. And then after his first heart attack in 1989, during his rehab, he put together a lot of these anecdotes into a little book called You Just Can't Hardly Believe It. And then he did two subsequent books, finishing with The Last in My Learning Tree, some medical anecdotes, and they're really interesting, and I actually have a copy if any of you want to look at it sometime. There's lots of CHEO stuff in there. They're really good. Jim was the ultimate gentleman. I think anybody who knew him would know that. He was absolutely adored by his patients. Many stories about them in his books as well. So it was a no-brainer that we named our visiting professorship after him in 1997. Sadly, we lost Jim in 2008. Ironically, it was the night before the Wiley Day that year. But his legacy lives on, and I know he would be pleased, he would be proud, and delighted to have our visiting professor this year, who's Ben Shore, a Canadian from Boston. And so I'm going to pass it over to Shay to introduce Ben.
All right, thanks very much, Dr. Jarvis. So for those of you I haven't met yet, I'm Shay Seth. I'm one of the orthopedic surgeons here at CHEO. I have the privilege of introducing Dr. Shore. He's an orthopedic surgeon at Boston Children's Hospital. He's an associate professor at Harvard Medical School. He currently serves as the co-director of the Cerebral Palsy and Spasticity Center at Boston Children's Hospital, and is the fellowship director there as well, which is where I got a chance to meet Dr. Shore and he's been my mentor since then, and been lucky enough to call him a friend since then. So we're very thankful that he's here today. From a clinical perspective, he's recognized as an international expert in orthopedic care of children with cerebral palsy. He teaches at all the major courses on the topic. He's a contact expert for all of our CP-related conferences. He's on the board of directors for the American Academy of Cerebral Palsy and Developmental Medicine. From a research perspective, he's a PI or collaborator on multiple multi-center neuromuscular studies. He's a co-founder of the Cortices Children's Orthopedic Trauma and Infection Research Consortium. There's over 130 peer-reviewed publications. On a personal side, he's a proud Canadian, grew up in Toronto, did medical school and residency at Western. He was actually visiting his family in Toronto this weekend, flew them back to Boston on Monday, flew back here last night, and then is flying back tomorrow for his regular OR day. So his ties here are very deep, and he remains very connected to our system as he remains very active as a instructor in our primary R5 exam review course for pediatric orthopedics. He's also a Royal College examiner still, which is amazing given everything else he does. He is legitimately the busiest person I've ever met, and we're very fortunate and thankful that he's found some time to spend with us in his very busy schedule. So Dr. Shore, welcome to CHEO, and thank you for joining us today.
It's great. It's going to take me a few minutes just to switch the presentation, so bear with me for those of you who are in the land of Zoom as I kind of navigate things. And as it's kind of loading up, I think the most stressful thing in this new era of COVID and hybrid presentations is just getting the audio visual to work. And I don't think I've ever been as stressed as I was this morning, but thanks to the team here, they really helped me out, kind of get things up and running. So hopefully, fingers crossed, this is going to work in about 30 seconds. All right, and then I just got to share my screen though. So that's good. Oh, can you guys see it in Zoom land?
You are sharing, you're good.
We're good. Awesome. Great. Thanks, Anna. So it's a real honor to come back home, relatively speaking. Although I grew up in Toronto, I feel like Ottawa's home. And as Shay was driving me here today, I recognized where we were close to the hospital because some things don't change, and the architecture in Ottawa is pretty consistent. At least it has been for the last 15 years or so. So I don't really have any financial disclosures to report that are relative to the stuff I'm going to talk about today. I will say it's an honor to be here. I tried to find as much as I could about Dr. Wiley online, and there isn't much. And I think the reality is that, as I was talking with Sasha last night, that kind of typifies the Ottawa way, you know, quiet, humble, kind of, but like amazing, and just getting the job done. And I think you guys have the benefit of experiencing all of these mentors to me that are right here in this room. So, you know, Baxter, I can remember meeting Baxter a long time ago because he was a Western grad, and everyone said, you got to meet Baxter. And when I was in my residency and in my fellowship, people said, you got to meet this guy, he's great. And we connected when I was very early on and have maintained a relationship. And then, you know, through the SPORC, which is the Canadian 50-year residency program, I met Jay, and we've become friends and stayed in touch over the last kind of decade and a half. And it's just great. And there are some of the other characters that took me out last night. And for those who came to dinner last night, I'm really sorry that my flight was delayed and you had to wait. As a Canadian, having a room full of people waiting for you often creates a lot of anxiety, and it didn't make me feel good, but I'm glad that these guys took me out for scotch, wine, and beer afterwards, so I feel wonderful this morning. And as Shay said, I'm a Canadian. I grew up in Toronto. I went to school out on the West Coast. My wife is from the East Coast. I like to think she talks like a pirate. I live in Boston now, so this is like my new version of North America. And, you know, I always debate when I'm going to come back. My children got their Canadian citizenship on July 1st this year, which was like amazing. It came in the mail. So hopefully I'll make my way back to Canada soon. I have a guilty pleasure. I started to make outdoor hockey rinks for my kids over the last 3 years, and Shay kind of experienced this, and we kind of caught the bug together. But this is kind of my version of crack. It's a little bit of feng shui, it's a little bit of meditation, but trying to get the ice as smooth as you possibly can has been my goal. This season, we increased the boards at the back there, but we only had 2 skating days in Boston because the weather was so lousy. So hopefully next year will be better. I'm a huge Leafs fan, and my family has caught the bug with me. So this was on Saturday night, watching the Leafs dominate the Canadiens 7-1, in case you didn't know about that game. But my kids got on the Jumbotron 4 different times, which to me was amazing. And we dressed up, my son and I. He was Austin Matthews in the corner, and I was Phil Pritchard this year, who's the keeper of the cup, for those of you who don't know. But that is one of my other things that I like to do. And the reality is that we all probably work a little bit too hard. And however you are able to carve out time in your life, you should cherish. And you know, Shay is right. I probably do too much and I say too much yes to too many things. But a couple years ago, when my kids started to play hockey, I said, like, this is important to me. And so I just started to change my clinics. And so they know in Boston that from September to March, I won't see anybody after 2:30 Monday, Tuesday, Wednesday, because it's hockey practice and I have to get to hockey practice. But if it wasn't for hockey practice, I probably wouldn't have carved out that time. And whether it's hockey practice or whatever it is, as physicians, it's really important for us to carve out time for ourselves, just for mental health and just staying sane. So I just on the side, you know, I thank my kids for kind of pushing me to do that, because I wouldn't have done it myself. I did my training in London. I grew up in Toronto, went to school out on the West Coast in Victoria for undergrad. You guys know where London is. Ottawa's right beside it, but you know, this is just for some of those Americans who don't always know. It's also called the Forest City, and I had the benefit of training with these like superpowers of orthopedics. I never really realized it when I was a resident, but at one point in time, we had the president of the Hip Society, the Sports Medicine, and the Knee Society, all when I was a PGY1 through PGY3. Now, they weren't always the nicest to me when I was a resident and I didn't know what I was answering, but these guys, Pete Fowler, Cease Rohrbeck, Jim Roth, and Bob Bourne were like the leaders for me and really shaped everything. And Baxter was there too, before my time, and he trained there. And also this handsome young man in the front here also came through after me, and after that they said no more. After my training at Western, I went to Melbourne, and this is what the hospital looked like when I went there. They've done a renovation, and this is the new Children's Hospital. I would say that if you are going to go anywhere for travel, this is the most spectacular pediatric hospital in the world, hands down. The inside of this hospital has a 3-story aquarium with sharks. So when you're in the emergency room, you can watch sharks swim around when the kids are waiting. In the clinics, when you're waiting for your patients, they have meerkats in the exhibit outside. So they have these windows, so the kids are just waiting, watching the meerkats, and then they go in and they see their dog. It is spectacular. So shameless plug for Melbourne, Royal Children's Hospital, phenomenal place. I went there because I wanted to surf. So for those PGY 5s and 4s who are trying to figure out their life, you know, take fellowship as an opportunity to travel, and because you're never going to get that time again. So take it. You're all excellent. You're well trained. You're going to be excellent physicians, but take this opportunity of fellowship as a time to go somewhere that you'd never go. And so for me, I'd never go to Australia for a long period of time. So I was like, I'm going to get stuck in and go there. And I was just fortunate to meet Kerr Graham on a Calgary gate course that was put on by a drug company that paid my way, which almost would never happen now. But the irony is I just ended up going to Melbourne. I didn't know anything about CP, and I was like, I'm going to learn how to surf. So my plan was to go to Melbourne for a year and then to go to San Diego for my second year. So I had 2 fellowships set up. And once I had agreed to Melbourne, the San Diego folks called me and said, well, you're Canadian and we can't get you to bill appropriately, so we're not going to give you a fellowship spot, after they had already given me a fellowship slot. So I was like running around, and that's how I ended up in Boston. But that's a side story. I came looking for surfing, but I didn't realize that as fellows, you're actually on the call schedule with the residents. So I was actually pretty busy, and I didn't do as much surfing as I had planned in Melbourne, but these were my 3 co-fellows. And we worked really hard during our fellowship. It's a wonderful fellowship, lots of autonomy for those who are thinking about going to a place like that. And it wasn't all bad. In my first month, I met my wife there. She's a pediatric dentist, and she's from Halifax, and she just happened to be in the same OR as me, and she was looking for the OR, and I gave her directions. And the resident at the time said, "There's no way you have any chance with that person. She is way out of your league." But like a true Canadian, I said, "Hey, if you ever want to watch hockey, you know, like you can come over to our house. There's a couple Canadians who are watching hockey." And anyway, so she decided to come back to Boston with me, and she got a job there, and then I had to get a job there after her, and we have two wonderful kids. So you don't always know where life is going to take you. If people had told me when I was a PGY5 that I'm going to Australia and then I'm going to be at Harvard, I'm going to stay at Harvard, I would have said, no way. And none of my co-residents still believe that I am where I am. So life is amazing. It's wonderful. And so just take the opportunities that you have and keep your options open, just because you don't know how things are going to go. I was fortunate in Boston to learn from these leaders. This was my fellowship year. I'm in the corner there. We've had other fellows that haven't been as good as me come through. Sasha didn't spend much time with us. He was mostly on the sports side, and I think they kept him away from me. So I think we figured out last night, maybe we only did a couple cases together. But what I'm going to talk to you about today are really not my words. They're things that I've learned along the way, and I've had these amazing mentors and leaders. And you know, I don't have the opportunity to come here and talk to you if I don't say a word about my newest partner. This is Colin Watkins, and we work together as a team. So I start the cases in the morning, he's able to shoot turkeys, and then he comes in for the second half of the day. And the same way, we did a surgery yesterday, and he's managing the patient at home while I'm here talking to you. So you have to build teams and partnerships wherever you work, because that's the only way you're going to be able to get through our job, because it's a grind, it's hard. And if you do it all yourself and you can't share it, it just becomes really difficult. And I came here before in 2010. Baxter and Jay will remember, they invited me. I was looking for a job. I was at the end of my fellowship. So I came here and I talked about cerebral palsy. My wife and I both came. We got in the car on the way home, and we didn't know what to expect about coming to Ottawa. And we just thought, well, we might as well go, you know, and do diligence. And we got in the car and we were like, oh my God, we love this place. We want to come. And then they said, well, you need someone to die. But really, I think they were waiting for Sasha to come. And so I was like, well, I can't wait that long. So I ended up staying in Boston. But we really loved Ottawa. So it's a real honor to come back here. Now, before I get into my talk, because I'm sure you guys are getting tired of listening to me just talk about stories, but I got to say a couple words about CHEO. Many of you may not know CHEO because he's new to the program and he's new here, but CHEO is amazing. And he was our fellow 2 years ago, and it's the first time we've really ever had someone who was really interested in neuromuscular during their fellowship. And Colin and I, my partner, joke that, you know, if Shay was there 2 years earlier, I probably would have hired Shay instead of Colin to be my partner. And so he is spectacular. We had a wonderful year. He was beside me on some really challenging cases and then some fun stuff. He was well liked by everybody, and we're really excited to see what he's going to do here. He's passionate. He's got a PT background, which is so healthy for orthopods. You know, he would go out and eat crappy food with me. We both adopt the fasting rule during the day and then eat whatever we wanted to. So he was my like cheat buddy. It's a real honor to come back. It's a pleasure to be your mentor. I can't wait to see what Shay's going to do. You guys are really fortunate to have him as part of your team. So with that, we're going to jump into this talk. So the talk, I have two main things I want you to walk away from at the end, okay? So these are the things that I want you to be able to apply if you take only two things away. So one is to be able to use the language of the GMFTS. So how common is that for you guys? Does everyone know what this is? Is this like common or still a little bit uncommon? Hands up for like, I use this every day. Hands up for I have no idea what you're talking about, or not really sure. That's okay. So it's good. So this is an important tool to use for communication. For those who don't use it every day, that's fine. But the goal is that at the end, hopefully you can use it every day. And then the other point I want to really hammer home for everybody in the room and also on Zoom is that the care for kids with cerebral palsy and neuromuscular conditions is not provided by one provider, but it's a group of people because it's multidiscipline care. And if we don't collaborate, work together, communicate, we don't really provide good care. And it's all just pieces to a puzzle. We can't fit and finish the puzzle if we're all working by ourselves. And this is something that I've learned over time, but I think is really the cornerstone of managing children with neuromuscular disease. So these are our objectives. We're going to talk about the gross motor function classification system. We're going to talk about how different allied healthcare providers work together to provide care. And then we're also going to talk a little bit about how orthopods kind of fit into that game plan and how they work. And so just to start at the beginning, cerebral palsy is a mixed bag of diagnoses that really involves some injury to a developing brain from when the egg and the sperm get together till about 2 years in life. And that represents a sensitive period in the brain where damage can happen. And it can happen from a host of different reasons. Probably the most common misconception is like a birth-related trauma, but that only makes up a very small portion of the kids that have cerebral palsy. And as we've gotten better over time, in the past, people who just weren't right got this label of CP, but the reality is with more genetics, we've become much more facile at trying to understand what are the masqueraders for CP. But in general, it creates difficulties in cognition and function, language, and behavior. And my mentor, Kurt Graham in Melbourne, used to say it's really the story about the tortoise and the hare. So I usually explain this to parents at least every day in clinic. And the concept being that in kids with CP, they grow normally with their bones. So their bones are growing at a normal rate, but their muscles are kind of like the tortoise. They can't keep up. So every time a child goes through a growth spurt, their clinical picture changes because they get tight again. But parents don't really understand that. So they think that the disease is getting worse, but the disease is static. It's just the musculoskeletal manifestations are changing over time as a child goes through these typical growth spurts that we see, 0, like a 2 to 6, and then 10 to 12. There are these clear growth spurts where things are good and then they get bad, and then we get them good again and then they get bad. So it's this common cat and mouse game that we have to play as healthcare providers for kids with CP. So the gross motor function classification system, always when residents are in my clinic and they're trying to figure this out, the GMFCS is just impossible to say. It's the GCMAS, it's the GCFSS, and then they just kind of screw it up. But it doesn't really matter. The bottom line is just to think about these numbers, and it is so intuitive. So rarely in medicine do we have a classification system that then can be applied to so many different things, and this is one of them. And what's so nice about this is it's a communication tool that I can get on the phone and call someone on the other end of the world and just say a few words, and they already have a picture of what I'm talking about. And that's what's so helpful. This is a relatively static classification system, and we'll go into it. And that's what's helpful about it. It's based on primarily sitting and walking. And the level 4 and 5 kids are the ones that we may focus on a little bit during the talk, because they're the ones from a resource perspective that probably at your hospital use up a large chunk of the resources. But very briefly, functional level 1 kids are those that really have no problems. You can hardly pick them up when they're walking outside. They run, they jump, they don't use any assisted devices. To differentiate a functional level 1 and level 2 kid, a level 2 kid has some problems, most likely on uneven surfaces. So if they're outside running on grass or at the beach, they have trouble. They may need to use a stairwell or a railing to go up and down the stairs. As you go to levels 3, 4, and 5, these kids now need some form of assisted device to kind of help them with mobility. So the level 3 kids primarily walk with assisted devices and maybe for long distances use a wheelchair. The level 4 kids are the exact inverse of that. So they do a little bit of walking, but most of their time is spent in a wheelchair. And then finally, the level 5 kids are those that have poor head control. Maybe they get up into a stander, but they really don't do any kind of meaningful walking. And so that's the classification system. And it may seem confusing, but if you start to practice this when you see kids and just apply it, it becomes much easier. It's like any language that you use in orthopedics, in medicine, in any part of your life. And what's unique about trajectories of children is what you'll see here. So this is a slide that just shows you age at the bottom. Gross motor function, or GMFM, is really just a surrogate for development for kids. So what we can see here is between the ages of 0 and 6, kids have an exponential trajectory of development. And that's good, because if you do any intervention between 0 and 6, you'll look like you're awesome. But the kids are getting better anyways. And so if you do nothing, they'll still get better. And so sometimes it's best just to leave them alone until they get to where they are or their plateau. And then we come in as allied healthcare providers. So between 6 and 15, our job is really to keep kids on the curve and not have them fall off the curve. And so that's the task that we have. And the challenge is the interventions for kids with cerebral palsy are expensive. 15 years ago, 10 years ago, it was estimated $1 million per child in US dollars. It's only way more than that now, and the interventions are super costly. Kevin does the fusions. Those are really expensive. The implants are really pricey. You know, if you do an SDR, people fly from all over the world. They mortgage their house to come get these SDRs that are supposed to change everything. And the real question is, does it make a difference? These are costly interventions, but they don't really change the underlying condition. You know, we are operating downstream from where the problem is. We talked about before, cerebral palsy is a central nervous system issue. It's a problem in the brain, and none of us are good enough to operate on the brain. So we're operating downstream. So they go to sleep, they have an intervention, and they wake up and they still have CP. We haven't changed that, right? So the real question is, do our interventions make a difference? And if you think about how we've looked at our interventions as orthopedic surgeons, this is a very orthocentric component, so I apologize for those in Zoom who aren't necessarily orthosurgeons, but we've done a very good job of measuring what are called care processes, right? These are range of motion, x-rays, mortality, infection rates, and those are great, but they don't really relate to outcome measures. They don't say how a child functions, and that's really what people care about. You know, these are the things we look at in CP. We look at range of motion, we look at x-rays, maybe some gait parameters, functional outcome, not so hot. And the challenge in CP is it's a broad spectrum. Kids are born with CP and then they become adults with CP, and you have to care for them along the way. And it's chronic, so you don't outgrow CP. That's the other challenge with it. And we don't really have great gold standards. So there aren't really great gold standards. We're just developing some new great metrics. The CP child is one that's excellent for GMFCS level 4 and 5 kids, but there aren't a lot of gold standards. And the challenges are meaningful changes in CP can be very small, right? So if you ask a family what's important to them, if a child who can't transfer independently can now transfer independently, it changes everything, right? They can now go to the bathroom themselves without someone helping them. But how you capture that on a metric is like a very small change, right? And so what happens is we can't really measure a lot of the changes that we do, even though they're very valuable to the families. And different than other chronic conditions, you know, CP, it's not a chronic condition where, from a medical perspective, you know, if you treat the medical perspective, they get better. That's not how CP works. You have a condition, you stick with it, you can't really outgrow it. And so these are all some of the challenges that make caring for kids with cerebral palsy challenging. But it's not hopeless. And, you know, like this picture says, I actually think that you can make meaningful changes. And if you are able to strike it right, this is the most rewarding population of kids to care for. And if you are fortunate to kind of get the bug and like doing this, your job satisfaction is exponential and off the roof. So I, on a regular basis, think about just how lucky I am. And if you had asked me that when I was a PGY5, or even when I was coming out starting to do caring for kids with CP, because a lot of people don't like caring for them for all these reasons, I would never have said that I would enjoy it as much as I enjoy it now. And so there's an opportunity there. And I'm just going to take it back to this hospital for a moment. You know, the vision of this hospital is the best life for every child and youth, and providing exceptional care to children and how we advance doing it. And so that's the challenge that all of you in this room have working at this hospital. And so how do we do that? So how do we provide this excellent care for kids with cerebral palsy? Because they all have very different needs, expectations, and wants. So it starts at the beginning, right? So we use this term, which is developed by the International World Health Organization, which is called the International Classification of Function, Disability, and Health. And the point of this really is to say that if I change a child's x-rays, that's not the only thing that matters, right? I really want to care how a child functions within their environment, how they're able to participate in sports, how they're able to do things that are meaningful to them. And that's where care starts. You have to figure out what's important to the child as well as to the family. And when we think about treating kids with CP, it's really a multidiscipline approach. The 4 pillars, I would say, are neurology, orthopedic / rehabilitation, complex care, and neurosurgery. Those are like kind of like the 4 main pillars of care for kids with cerebral palsy. And that's what we use at our hospital. Now, when I started 15 years ago, we were trying to figure out how we provide care for kids with CP. And I would argue that it's not any different than the way it is here at CHEO, is that kids with cerebral palsy or any neurodevelopmental disorder come into the hospital in very different ways. They may be fortunate enough to present to CHEO or to the rehab physicians here, but they may just come because they have seizures and see a neurologist. And if the neurologist is just managing their seizures, they just keep managing their seizures, and no one actually does anything for the musculoskeletal problems. Like no one's managing their braces, no one's telling them they need an x-ray. And that's because kids are coming in at different areas of the hospital and the care is not consistent. So when I came back to Boston, that was clearly what was happening. And I was trying to figure out, how do we make it better? And here's just a schematic. So when we came back to our hospital, you could just put CHEO right here. I bet you it's exactly the same. So when you look at the kids as they come into the hospital, they come in very different ways. So some see just neurology, almost half. Neurology is huge, right? Because there's so many kids with neuromuscular problems that have some element of seizures or cognitive issues. Some come to ortho and rehab. Physiatry is rehab in our world, but some people use the term synonymously. A few meet both. Some just see the complex care docs. Some see neurosurgery because they have a shunt or they have a problem related to a baclofen pump, and others just come in different places. But the reality is kids come through all of these different areas and access points in the hospital, and regardless of where they come in, they get different care. And so we're not really providing a consistent level of good care to the kids, because if they come in at one place and they're not being communicated, they never really get the care they deserve. And this is the problem in most institutions without a centralized place for cerebral palsy. So, my first question when I started was I was trying to do these research studies, and they said, well, how many patients do you care for with CP? So I got to talk for a moment about Drake. So Drake, or Aubrey, grew up in Forest Hill in Toronto with us. Went to school with my youngest sister. He's not a gangster. He lived in Forest Hill, which is a very affluent area, and worked at the Shoppers Drug Mart with my sister. But, his song is I started at the bottom, right? And you have to start at the bottom, right? So I would say to you, how many kids with CP, I'm going to just throw it out to the universe of Zoom here. How many kids with CP are seen at this hospital? Do you guys know? Do you have any idea in the room here? Do you have a sense? Baxter, what do you guys think? Jay?
I have no idea.
In the room? Anna, what do you think? I know I saw you there. I don't know if you can come off mute. Oh.
I can run, but I can't hide.
Yeah.
Here we go. Sarah, are you there? Because we have the numbers of broken down by GMFCS.
Right.
Sarah
So,
Bigford has it.
okay.
My guess is 300, but
Right.
again, as Dr. Shore mentioned, those a bit of a guess because they are scattered a little bit throughout the hospital when they're not seen through the Children's Treatment Center.
Right.
And
So,
I'm guessing that's an underestimation because it's 2 in 1,000 and we have a catchment area of about 1 million.
yeah, if you think about what the prevalence is for CP, it used to be when we were trained, when I was training, it was about 1 to 2. It's now slightly increasing just with our improved neonatal care. So it's somewhere between 2 and 4 per 1,000. So if you think about that, you're grossly misunderestimating your numbers, right? And the challenge is these are all diagnoses now that go with CP. And it took us in Boston with a lot of different analytic people several years to figure out what our population of CP was. It's not an easy thing, but you can't start to make things better here without knowing who you're taking care of. And if they're coming in at all these different places in the hospital, you can't figure it out. So once we defined the population, we then showed the hospital this stat. So kids with CP are complex, we know that. Once the hospital knew what our population was, they found out that 10% of all the hospital charges in the last quarter were for kids with CP. So they were like, oh, wait a second. These kids actually in the United States make money for us, but even in Canada, they make up a large portion of the care that you provide. And so, the non-ambulatory patients, those 4s and 5s, had over 10 subspecialty providers in our institution. And so we recognized that this was a population that was really important that we needed to provide care. So that was kind of the impetus to drive our center, or our complex care center. And there's lots of literature that shows that you need this complex care team around you to provide multidisciplinary care for kids with cerebral palsy. This young man came to me from Vermont, had not really gotten any care. Shay remembers him. Unfortunately, he's passed away since we cared for him, but he came with horrible dislocated hips, tremendous pain, cachexia because he didn't have a feeding tube. All of these things from untreated management and spasticity. And I think the challenge is, this is the natural history. If we don't do anything and if we don't provide the appropriate care, a lot of these kids end up with something like this. So the impetus for us is to try and do something, but it's not easy. Like the title of the talk says, it does take a village. It's a coordinated system. So I'm going to focus for a moment on just the perioperative event. You know, if you are going to take someone, so Smitty's got to take someone for a spine surgery, it's not easy. It's a real heavy lift because there are all of these multi-morbid problems that the kids have that make them fragile, and they have a bunch of medications. And it's hard to know as an orthopod what's safe and what's not safe. It's beyond our pay grade. We need help. We need help from the neurologists. We need help from the complex care providers. We need help from the rehab doctors. That's the only way we can be safe, because what happens is, if you don't have that help, you discover these significant health issues either in the perioperative period or in the acute postoperative period, and then it creates a lot of medical issues for the patient and the family, or results in delays in surgery. And so much effort goes into surgery that you really can't afford to have surgical delays. So we recognize that at our institution. So we created this board runner system, and you guys are on Epic now, so I think you could do something very similar. So anytime someone is flagged with a complex hip or spine surgery, a booking form goes out. It goes out 6 months before the surgery, usually just because of our wait times, and I'm sure your wait times are no better than that, if not longer. And what happens is it gets flagged and it goes to a complex care meeting, which involves complex care providers, neurologists, anesthesiologists, and surgeons. And we go through each case and we say, okay, what does this person have and what do they need to have done? And what do we need to do in the next 6 months to get them ready for surgery? And if everything's sorted out, then they may see the complex care provider 3 months prior to surgery, but nothing else needs to be done. But if they need stuff done, they're actually taken off the list until they're ready to go, or they're held in a document in like a holding pattern. And once we do this, it does a couple different things that were added benefits that we didn't realize. By meeting with the family a lot, you're able to talk about what their expectations are, what their concerns are, and you start to make some shared decision making. Now, Juliana is a good friend of mine from Melbourne. She's a complex care physician there, but this is her slide, so I just thought I'd put a picture of her. You know, the reality is that all of these issues are issues that we need to discuss at the time of surgery or getting ready for surgery, and there's no way that one provider can have all of these discussions. And there's no way one provider knows all of these things. The only way we can address all of these issues is by working as a team and collaborating. And by doing a model of shared decision-making, we really talk about what are the goals for surgery, both from the surgeon as well as for the patient and the family. Often the patient can't articulate what those goals are, but the surgeon can talk about it and the parents can talk about what are the primary issues for them. What are my concerns? What do I want to make better? And by doing this and talking about all of these issues, you get prepared for surgery much better. So it's not so much of this overwhelming, traumatic experience. If you go on any Facebook messaging group about kids with CP, every parent will say, hip surgery was terrible. Spine surgery sucked. The pain was tremendous. Because a lot of the time we don't really do these things. So we don't optimize the care experience for the family, and they just feel like they just got railroaded. And that's on us. We have to do a better job of preparing our kids for surgery, because the reality is it's not just the x-rays, right? So for us as the orthopods, we look at this and we say, all right, giddy up. I know what to do here, okay? I'm just gonna do it. Get down and we're gonna get going. And that's what we're gonna do. But the reality is it's not that easy, okay? Now, the surgery for orthopedics has evolved over time, and Mercer Rang really popularized this concept of not trying to take one orthopedic problem and do one surgery at a time. And the reason why is because then it means that a kid spends every year in the hospital rehabilitating. So now we do this thing called single event multi-level surgery, where we kind of do what we term the get down in Boston. That's what we call it, little get down or big get down. But really it's just a sequence of surgeries, 8 to 12 to 16, done in one hospitalization, one rehabilitation. And we think that helps because it doesn't allow kids, it allows kids to be as normal as they can be. So they have their rehabilitation and then they move on. And the reason for that is that rehab takes forever. It takes, you know, between 6 months and 2 years to kind of get back to normal. And so if you're doing all these little interventions, it's just very hard for kids to live a normal life. And you don't have to do everything all at once, but we try and do as much as we can. And if we just focus on hip for 2 seconds for the residents, this is the problem. We go back to the GMFCS, right? 4s and 5s, those are the kids that don't walk. They have a very high risk of hip displacement. And we define hip displacement as a migration percentage where 30% of the hip is out of the socket. If we look at spine, it's the same thing. This is looking at the frequency of spine problems. 4s and 5s are in yellow and red. Again, you see the same thing. Scoliosis is related to GMFCS. If you looked at medical complexity, you'd see the same curve. So a classification system that's so simple works so well, okay? And what are the problems with any hip and spine issues? If we just focus on the 4s and 5s, the main issue is that these kids have problems with their activities of daily living, whether it's increased caregiver burden, decreased ability to sit, problems with breathing, respiratory issues, GI issues, ulcers, etc. It all affects their health-related quality of life. So the goals for us as surgeons and other allied healthcare providers is to try and improve their quality of life, decrease their caregiver burden, allow them to do the things they want to do. And so for 4s and 5s, that is really simple, right? It's being able to sit and being able to stand. And the nice thing about the GMFCS is it helps you align your goals with your families. If someone who's a GMFCS level 4 comes in and the parents say, I want to walk independently, then you spend some time saying, look, there's nothing we can do to align that goal. Let's reevaluate your goal and try and change it to make it more attainable. And even this is a great study from the HARMS group that really looked at the GMFCS level 5 kids to create a new classification scheme based on these medical comorbidities. So for the trainees in the room, if your kids have these problems, these are like GMFCS level 5.1, 5.2, 5.3, and 5.4 based on how many of these things they have. So if they have all of these issues, you know they're going to have a little bit of a harder time going through any perioperative course. So they're the ones that you really want to spend the time optimizing appropriately. So once we created our center in Boston, we started to say, okay, let's start looking at some data. Now that we have a population of kids with CP, let's try and generate a cohort. And this is what I learned from Kerr in Melbourne, is that if you can create a cohort of kids and follow them over time, you can write hundreds of papers on that cohort. So he had a cohort born from 1990 to 92, all kids with CP, and he continues to write papers on that cohort. Because if you take the time, put the effort in, and create a research cohort that you can then study over time, you can continue to ask questions. And so we did something similar in Boston where we just looked at our cohort of kids. Once we were able to define the population, we just wanted to say, well, how well do femoral osteotomies work? And is there a success rate? And the curve is kind of hard to figure out here, but this is a survivorship curve. And it really just shows you that the success rate decreases, not surprisingly, in GMFCS level 4 and 5 kids after VDRO over time. Now, the success rate's about 37%, and I would be remiss to say that the group here in Baxter wrote a very strong paper about combined VDRO and pelvic osteotomies that we're going to talk about later. We're not talking about it now, but I haven't forgotten, Baxter, don't worry. But the strongest predictors, at least at our institution, for success was age, which we thought, we knew. The younger you are, the greater your chance you're going to have a revision. Functional level, that makes sense, but what we didn't realize was the third one, which is surgical volume. And this gets to the point about creating a center of excellence. In every other thing, if you look at the cardiac care in Ontario, they closed centers down because they wanted to have a few cardiac centers with high volume to have better outcomes. It's really no different in neuromuscular care. If you're doing VDROs once in a while, your skill set's just not as good. And so the outcomes for the kids are not as good. And in our group in Boston, we have over 30 pediatric orthopedic surgeons. So there were some surgeons that did this every single week, and there were some that did it maybe once a year. And the outcomes were very different with surgical experience. So it's just an important thing to think about as you try and build your center of excellence here. We then looked at health-related quality of life in that same cohort, and we followed kids for 2 years and then 5 years, just trying to say, because the residents often, when we're doing these cases, are like, why are we doing this? This kid doesn't walk, they don't talk. Like, why are we struggling to do this osteotomy? I'm sweating, this sucks, I hate it. Like, what's the point? And, you know, in the past we said, oh, well, the hips are in the socket now, we're happy because we've made the x-ray look better. But we never really correlated that with health-related quality of life. And thankfully, Uni Narayan in Toronto was able to generate this CP Child score, which is a great provider caregiver assessment tool for the GMFCS level 4 and 5 kids that can't speak. And so what we showed is that hips that look bad actually are bad based on health-related quality of life. And that when you do CP surgery and you put the hips in and you do a good job, their health-related quality of life changes and improves. And it improves at 2 years. But then also now we've just published the 5-year data. And in the 5-year data, what's really unique is we looked at the spine and the hip kids. So we found that the hips got better at 5 years. The spine kids got better at 2 years, and then they regressed back to their mean. Now, not everyone necessarily agrees with it, but I think the only issues is that these kids have lots of medical issues. And the CP child really captures caregiver burden. The caregiver burden doesn't go away, right? Remember, we're operating downstream. It may make them a little bit easier because they sit up straight, but they still have their issues with respiratory problems. They still have their GI issues. They still have their tone, and all those things affect caregiver burden in a negative way. So I think it's just important to recognize what we can change with our intervention so that we have honest discussions with families. And then we looked at barriers to discharge. So we looked at our institution, we said, what is stopping kids from leaving the hospital? How can we get them out of the hospital, make this experience better? And I'm just talking about hip and spine stuff. What we found is that in our cohort over 2 years, almost 3/4 of the kids had delays that were greater than 1 day for leaving the hospital. And when we looked at what those delays were, the majority were equipment, education, and parental comfort. Those are the top 3. Those are all very modifiable issues, right? It's just a matter of preparing for your perioperative event, educating parents. If you look at total joints, what do we do in total joints, right? They go to joint school ahead of time. Patients see the PT, they learn about what their exercises are before they have their total joint. They're taught about what their hospital course is. So when they come into surgery, they have their surgery and they get kicked out real quick. Why can't we do the same thing? So we started to do something like that by just having a case manager. So we said, we're going to allocate a case manager to CP. We're going to see what happens. And so in the first 3 years, we were able to decrease our length of stay by 1 day, 1 full day for every single kid that had neuromuscular surgery. And that was just doing equipment. We haven't even started the education piece and the CP school are creating like a little video for parents. But there's ways that we can provide care better than what we're currently doing. But I think just to take it back, this is the takeaway point, wrapping it back, it does take a village. Teamwork makes the dream work. It sounds corny, but like if every provider here is individually practicing and not communicating, it doesn't work. Before we had a center in Boston, we would all see patients and then we would spend all this after hours time communicating by email, trying to make appointments. It was not good use of our time. You get one person who's in charge to coordinate these patients. They're able to book and schedule. That makes your life so much easier in terms of communication. Comprehensive care is necessary. It can't just be the orthopedic surgeon. It can't be the neurologist or the physiatrist. And having pediatricians help care for these medically complex patients is critical. And then we just have to have open lines of communication because ultimately we got to care for these kids. So we got to find a way to do a better job. So I hope you guys have enjoyed this. Thanks a lot for your attention and happy to answer some questions. Thank you. Okay.
Yeah, so thanks very much, Dr. Shore. That was really phenomenal talk. It's really interesting to hear some of the really baby steps that you guys took early on to start growing what has become really one of the world leading centers in taking care of children with CP. So it's really interesting to hear some of the really small things that we can start to implement here. Are there any questions in the room to start with before we head off to the Zoom questions?
I will just thank Shay because, you know, he asked me to give a talk that I've never given before. So I put a fair amount of work into this talk just because I didn't take, Smith told me just to do a can talk, but I just didn't want to do that for you guys. So I tried to make something different and we went around a bunch of different things. But for those that are listening, I really do think it's very easy to just tune out here and say, this is too hard for us to do. We're not going to do it. And we're just going to stick in our way. For sure. The easiest thing to do, the path of least resistance, is to stay in mediocrity or where you are and say, we can't do this. It doesn't apply. Whatever we're doing in Boston can't be done at CHEO. And I would challenge you to do something different because I think I think you can make it better, and I think we need to collaborate more, because that's the first step, is trying to figure out the population, try to figure out ways that groups can communicate to try and improve the care.
And one question online was about post-op with pain, and how are you managing them and families for pain after discharge?
Yeah, it's such an important part of the care. And, you know, for the first decade of my practice, it was Valium and oxycodone, and mostly just oxycodone, right? And that's such an ortho way of managing something. It was just like kind of stupid. But what I've realized is that there's so many other multimodal medications to help out. And it's well beyond what I know, but we now use our complex care physicians. And so most kids now, they're preloaded better. So before their surgery, they start taking gabapentin. If they're not taking gabapentin, everyone starts taking gabapentin before surgery, and they take it during the perioperative period. That helps out tremendously. I feel strongly that regional blocks are critical for these kids. So epidurals, single shot blocks, but anything that can reduce the narcotic use when they're in the hospital is critical. And then afterwards, it's Valium and tone control, so that if they don't have a good rehab doc that's working with them, the challenge is that that's going to create most of their issues. So some of those kids, if their tone is terrible before surgery, we won't do the surgery. We'll put a pump in first, or we'll do a palliative SDR, or we'll do something to help manage the tone before we do the ortho part. If you just look at the x-ray and lick your chops and say, let's just knock this hip in, and you don't look at everything else, it's going to be a real problem. Now, I'm not saying we're experts and we still struggle, but using the complex care teams to help us have been amazing, just because they are much more comfortable with polypharmacy. Like most recently, just 3 weeks ago, I had a kid that I was just giving Valium and oxycodone. We were just giving the normal stuff. And they came back at 3 weeks and they're like, he can't sleep, he's miserable. And it's like the first time I actually looked at the MAR in full disclosure and saw what he was taking. He was taking like tons of all these other meds. So what we were giving him was like nothing. It wasn't enough. And so then we asked the complex care team to help him, and they totally, within a week, were able to optimize him with the right medications and then weed him off of it. And he's doing great now. But it just shows we're just not always the experts in it. We need help.
I think Dr. McCormick has a question on that.
Hi, Anna.
Hi, Ben.
Nice to see you.
A quick question. It's great to see you. I guess the breaking down the walls question, I think that's an awesome idea. And we've tried to develop something called the Optimus Clinic, which sees individuals with a difficult tone problems. So I always mess up what the letters stand for, but it's the Ottawa Tone interprofessional team, essentially. And we're really advocating for, so us docs have gotten together, neurosurgery, myself and Dr. Alazem and Shay and our plastic surgeon. But oftentimes when we look for support for such settings, it's difficult, like getting either admin support, nursing support, getting therapists involved in those types of things, because there's wait lists everywhere. So and that's, I guess my question is, how do you make a case when your neurology wait list is X number of years, or your complex care team wait list is so long? I am super supportive of this model of care, absolutely 100%. I think a tune-up pre-op is really important piece, and I think it would change some of our post-op issues and problems. And I think improve quality of life, decrease length of stay, improve the experience of the child. How do you break through all of the, oh my gosh, we're so busy already?
Well, I think you have to be creative, right? And there are some creative models. I don't some of the people in the room, right? I would say like Kishore in Vancouver has been incredibly creative at generating resources for, the care of kids with hips, right? He's gone to wealthy families and done a lot of real crowdsourcing for resources to help kind of involve and advance the care. And that's just been by kind of doing a slightly different model. But I think we have to go back to the administration here and say, okay, this is your vision, this is your mission. These are the most, some people would argue, the most needed population that you care for. They can't advocate for themselves. They're disabled. They have a high need for medical resources. We know what their natural history is. This should be part of the hospital's mission and goal. And so you have to kind of get a little bit, I think, of buy-in from the institution. And then, you know, you got to think about, we can think about other ways to do it. So like we have the same challenges with the neurologist, right? And so what we did is we used a nurse practitioner as a physician extender. So they see now all of our new assessments and they just kind of triage them to say, okay, like this person really needs to get into this person, but this person actually really doesn't need them. Because they may not all need neurology for the same things, but there's the ones that maybe need really urgent care. And you can't really triage from a piece of paper, right? And so trying to find, well, the other thing we've done is we've created like a pretty good 2-page intake form that just an administrative person reviews with the family so that when we get a referral to the CP clinic, we triage them. So it's not, they all don't need to see all 4 of the pillars of the care providers right away. They may only need to just get in and see the physiatrist because they have some questions about a brace, right? But then there's maybe one that needs to see everybody, and so they're prioritized a bit different. So I just think that there are ways to work within your system. I think we have to be creative. There's no question that you guys have a lot of barriers to provide care. I'm just kind of pushing you, I think, to say, like, let's see if we can do little things to start, right?
Agree, and I think this is a wonderful talk and a wonderful opportunity. I see some ideas being coming to me directly, and Ben, I hope you will come back and we can show you all the wonderful changes that you have inspired us to make.
That would be great.
Just talking to the time, we know that people are going to start dropping off the Zoom and people have to go off to clinical duties. That's fine. It looks like there's one more question in the chat, which Dr. Shore can address, and then just want to finally just say thank you to. So I mean, Arthur residents, you have to be here, so thanks. But to our pediatric colleagues for letting us share their time today. To our rehab folks who are down, to any of the administrators who are online and joining us today, thank you very much for joining. It really, as we work towards building some of these models that Dr. Shore has talked about, and in terms of taking care of these children as well as we can, it really is important that we all are working together. So thank you for just spending the time today with us. So, Dr. Shore, I'll let you address the last question, and then we'll kind of
it's just great that it's a multidiscipline forum, and I think that's the start, right? Like you guys just got to start saying, okay, we got to find a way to start meeting together as a group, and maybe it's like once a month or once every 2 months you just meet and you start saying, okay, what can we do? How can we share information better so that we can help optimize, you know, the perioperative care, but just the global care. The other question that someone asked about was like the other masquerading diagnoses. And I think that's super tough. We are very fortunate. One of our new neurologists has a very large NIH grant that's looking at this exact issue. And so any kid that looks like a duck, but's probably a chicken, I usually send them to him and he just does a swab of their cheek and we get their genetic testing. But I would tell you, I would argue, you know, the teaching when I was a trainee was that 80% of CP has the classic periventricular leukomalacia that you see on an MRI, and 20 to 30% has normal MRI, but it's still CP. I would tell you that that 20 to 30% is just something we don't know what it is now. It's not CP. It's either HSP, it's a genetic issue, and now we're starting to diagnose that 20 to 30% much more. And so perhaps it might be just here trying to figure out within genetics, is there somebody who maybe could get excited about this? Because if you get someone excited about it, they can write about it, they can drive it, and then they're your partner. And that's what we've got. We've got one guy, Dr. Sid, and he's awesome. And he's like my Sherlock Holmes. And I'm like, Sid, I don't know what's going on with this person, but I don't think they got CP. And then he'll start looking and trying to figure it out. So I think it's just trying to figure out who you can partner with at your own institution. So I just thank you guys for your attention, your time. I hope you don't get tired of hearing me talk today.
Thank you very much.
I guess I gotta leave. I probably can leave. Oh, is this going on all day?
No, we can.